where the stigma was really high, but now it's a new day. And I decided to address intermittent use take-homes. So while this guidelines for take-homes has been evolving, we're probably on version 42.0 at this point. We had the whole team, including clinicians, help us decide how we were going to improve take-homes for those particularly that are still currently using. So the earned take-homes, we did fast track that so people get to 27 take-homes faster. But today I just wanted to talk about the intermittent use. I think it was about 2 years ago that I heard here that some people were measuring levels of substances in the urine to see if somebody was trending towards less use. And we talked about were there other ways to look at trending. And so what our clinicians and the team decided is that we could look at their recovery progress. During that time, we also decided to close on Sundays. So everybody gets a take home on Sunday. But beyond that, probably 55% of our 310 clients get more than that one take home. So we're doing pretty good in that regard. And the things that we looked at were, is there less use, less different substances showing up in their urine? Are they reporting less use? We decided not to do actual measuring, but just to use reporting. We looked at what are their increased safeties and supports. So their chances of doing well and not diverting or overusing their methadone. And we also looked at engagement. Not required, but if they were engaging more with their clinicians, that was considered a positive. Other things that I didn't list here, or were they working? What were the other things that were doing that they were more motivated to keep their take homes? So we had step 1 and step 2 for earned take homes. So we added stage 0 for the intermittent use. And we looked at, again, at attendance, how long they've been in programs so that we know them, we know what their trending is doing. You know, could somebody get them earlier? Certainly if they came to us with take homes earlier, we could. And for everybody that got the one, I could probably, the Sunday one, I could probably count on one hand the people that were not returning their bottles, you know, or having struggle even with that one Sunday. But most people do fine with these 1, 2, or 3 take homes. We looked at their screens, again, fewer substances, protective factors, and the clinician is really the one who advocates for these intermittent use take homes. They're the ones who know best what's going on with the client, particularly in these initial stages. The medical team knows more when somebody's in trouble or if they have a complex medical history. But early on, it's really the clinicians that are advocating for this intermittent use, and they decide whether they get 1, 2, and whether or not these are back to back with the Sunday take home. Most of them aren't. Most get the Sunday, come a day, and then they can get 1 or 2 of the additional. But it's really worked out well. So again, we have over 55% of our clients getting 1 to 3 or more take homes, and we have 17%, 18% that are getting 27 or more because people are progressing. People really are finding that it's been a carrot for folks. Once they get these, they feel like, oh my God, my life is normal. We do take into consideration if they have other medical appointments too, because we don't want to add the burden of coming to see us if they're doing a lot of other medical things. So that's where we feel like we've made some headway. And early on, you would not have seen me in the fans of take homes while continuing to use. So it's been a good change. It's been positive, and I can reassure you that it is something that we can do.
I can't remember our order of things. Yep, Peter. So just the next slide when you think you're done so they know where they're going.
Everyone hear me? Good morning. I'm Peter Cassis, Chief Medical Officer for HCRC Baymark's OTP division. Today, I'll share our work on methadone dosing strategies in the fentanyl era, focusing on results from a multi-site pilot we conducted and how we've scaled these efforts nationally. As you know, with the increasing prevalence of fentanyl, traditional methadone inductions have not satisfactorily met the needs of patients with high tolerance from potent opioids, leaving them underdosed and at higher risk for dropout, continued opioid use, overdose, and death. To address this problem, Baymark piloted new high-dose induction strategies in New Mexico, Ohio. Oops, excuse me. Let me go to the next one. New Mexico, Ohio, and California between 2021 and 2023. We tracked safety, retention, and fentanyl toxicology outcomes. This is a poster we presented at ASAM. The results were very encouraging. High-dose induction proved safe and well-tolerated with reduced fentanyl use and improved retention. These findings strongly supported high-dose induction as both safe and effective. Beginning in 2024, we took what we learned from this pilot to build a national initiative to offer rapid induction across Baymark OTPs. We developed clear and easy to follow protocols to guide safe and consistent implementation. This is what that framework looks like. For patients with high opioid tolerance, particularly those exposed to fentanyl, we implemented a rapid induction pathway with the goal of faster stabilization while assuring safe administration of methadone. Eligibility includes intentional fentanyl use, suspected exposure to fentanyl-contaminated opioids, and a history of high opioid tolerance. Relative exclusions include patients over 65 years of age, those with alcohol or unprescribed benzodiazepine use, and those with severe medical or psychiatric conditions. Of course, not every patient needs or wants rapid induction. For those who do not meet criteria for rapid induction and those with modest or intermittent opioid use, low tolerance, or a recent opioid-free period, for example, after incarceration or residential treatment, we may opt to continue to use a traditional dosing strategy. Our current framework provides a set of 3 induction options: 2 protocols for rapid induction for patients with high fentanyl tolerance, and traditional induction for those with lower tolerance, medical contraindications, or a strong preference for a lower starting dose. In this side-by-side comparison, you can see that both the moderate and high-intensity pathways typically start at 40 to 50 milligrams with daily increases of 10 to 20 milligrams until reaching 80 to 100 milligrams within the first week of treatment. After a brief pause of up to 3 days, dosing can continue upward 10 to 15 milligram per day every 2 or 3 days until a therapeutic dose is achieved. With all these 3 approaches, the principle is the same: to reach an effective dose safely and as quickly as possible while tailoring treatment to each patient's risks and needs. To track the impact of our new dosing strategies and rapid induction, we established clinical benchmarks. For day 1, for 75% of patients to be at 40 milligrams or greater. At day 15, for 60% of patients to be at 100 milligrams or greater, and at day 30, for 50% of patients to be at 140 milligrams or greater. These benchmarks, based on our pilot outcomes, were designed to encourage and set organizational expectations for broader adoption of rapid induction. I'm pleased to share that we are seeing steady progress with more programs consistently meeting or even exceeding these targets. That said, measuring our results has not been without challenges. Our EMR often misclassifies patients as new after payer changes, and guest or jail doses can be mistakenly included in the counts. Our next steps are to refine our data processes and add patient and provider surveys to capture insights that numbers alone can't provide, strengthening feedback loops for our treatment teams. Despite these challenges, we are proud to share important successes. Over the past 12 months, we successfully implemented our new dosing strategies across all 145 Baymark OTPs with a true national rollout. This was accomplished through a comprehensive approach that included development of new policies and procedures, national provider and all staff trainings, program-based education, one-on-one mentoring, and regular program review. The changes we've made, along with changes in our take-home practice, represent significant shift in our culture. While we initially met some resistance from providers, nurses, and counselors, buy-in grew quickly. Today, rapid induction is widely accepted as part of everyday practice by both staff and patients. And the impact has been clear. We see stronger patient-provider rapport, patients feeling better, more engaged, and using less fentanyl, fewer early dropouts, and improved retention, and importantly, no known adverse events or overdose fatalities. Thank you.
Hi, I'm Sandra Gordon. I'm the medical director at Baco. And what I wanted to say, our program has continued to implement the changes that we spoke about last year in terms of having our multidisciplinary rounds, really just trying to incorporate a lot of the feedback from our staff so we can really provide great patient care. Okay, so one of our goals, we really try to expedite the induction process, as we all clearly have heard from everyone who's spoken so far. It clearly helps our patients stay in treatment. Also, one of the things that we talk about is really, we want to provide that really safe and efficient care and really treat our patients as they truly deserve, to have the compassion and respect. As we've said here, a lot of the times they really don't feel this, and we really try to make sure they feel that in our clinic. One of the things that we've done, we've changed our rapid induction protocol. We've adjusted it from the 40, 50, 60 to the 50, 70, 80 milligrams with ongoing titration, usually over 2 or 3 days. As everyone knows, we usually stay around 3 days before we continue up with their titration. One of the other things that we've incorporated is that we said here before, we used to just think of split dosing only for our pregnant patients, but actually I have learned really to do the split dosing, particularly in patients who are still struggling. I have several patients who are really, I met with them and they're really doing much, much better on the split dosing. I know one slide of me, but it takes time for some of us to change, okay? And so I have to say, it's really been quite remarkable. And I would encourage others to really think about split dosing, along with what Robin said, even with patients who are still struggling, you don't have to have these pristine urines. And one of the things I didn't mention on here that we are also doing in our program, we are also offering the methadone to bupe transition. We started that last year. One of the things to see. This was, okay. Oh yes, one of the things that not so much about this strength monitoring. Nursing competency, we really wanted to encourage our nurses to be a part of this process, along with our clinicians, because we feel like it's not just the medical team that's sort of bringing down these changes, because a lot of people are not ready to change, including myself at one point. So we really wanted to embrace, have our nurses learn about what we're doing. We're having them come to our programs. We've also did something called dedicated pump training, where they're able to kind of practice on our, what we call our SMART system, because sometimes things happen in clinics. And so we've had these sort of simulation episodes where they can assess for what we call high risk scenarios, so that there's no misdosing, that we can actually keep the clinic running smoothly. We've also had installed a third methadone stave so that we can have methadone for those emergencies. Oh, one of the things I should mention, when I talked about strength monitoring and dose precision, what we do at our clinic, we are able to see methadone levels. We are able to see other substances that are in the urine. And one of the things that it helps me, I'll say to the patients, look, you're really struggling. This urine is like a Christmas tree. Everything is lighting up. I mean, there's just everything there. Why don't we think about a dose increase? And so that has been very helpful when we've done our sort of urine tox screen monitoring. And also for patients who are unaware, they are aware of xylazine, but when they actually see it in their urine, like, oh my goodness, I've got xylazine in there, you know, so we can talk about it. Look, if you see this wound that's non-healing, let's try to make sure you take care of it so it doesn't fester there for months and months and months. And probably many of you are already aware, I've learned from patients, I think it's called the honey, what is it, the honey? Manuka honey, never heard of it. I learned things so much from our patients. They go, Dr. Gordon, you haven't heard? I said, no. And so we all learn from each other. And that's sort of one of the things I love about working there. And also one of the things we've also done is increase collaboration with Care One facilities. We all know our patient population is clearly aging. We've got patients who are undergoing had a hip fracture, knee replacements. They need to be able to have coordinated methadone care. They need to be able to get continuation of their methadone. And so far, it's worked out quite well with Care One and other, I think I forgot the other SNP. But anyway, we're working with those programs to really make sure our patients continue to get access to their methadone treatment. We're working also with the Gavin Foundation. So when patients come from there, they continue their dose escalation. We're also working with Boston Community Crisis Stabilization. So just trying to ensure that our patient population gets the care that they need in a timely manner. One of the other things we've implemented, well, patient-centered enhancements, because that's what we're here to do. And we have a patient advisory board, so we can really hear what some of their concerns are and their requests. They've asked for CPR training. They're in the midst of all of the overdoses. We do our one CPR training a year, right? I've never had to use it outside of the hospital. Our patients are in the midst of mass and CAS, and they need to know how to do this efficiently and effectively. We also incorporate a music therapy with one of our clinicians. We have another clinician that's embedded on our first floor, and it just allows, you know what can happen from the first floor to the fourth floor. Our patients get lost, they get diverted, all things can happen. So having a clinician down on the first floor can help smooth things out so that their requests are heard, their concerns are heard. If they need a dose increase, they can quickly tap on the nurses so they can get back to us as the providers. Our counselors also just in, talk therapy, because our patients clearly have a lot of life stressors and sometimes poor tolerance of stress. And let's just skip that one. But anyway, they are using their DPT skills. One other last thing I just want to mention. So with the recommendations that we've gotten over the past few years and the changes that we can now implement, we're continuing to mold and sort of adapt our clinic so that we can really provide the care that we need to help it run more smoothly. So we've seen where some of our bottlenecks are, how we can improve efficiency. And clearly, I feel that our patients feel satisfied. They've told their clinicians that things seem to have it's not such an edge. I don't feel that tenseness when you walk in through our sort of waiting area. It really just seems like things are moving more cohesively. And once again, our motto is our patients deserve efficient care delivered with compassion and respect. Yes.
Good morning, good morning. I'm Chris Ortiz, and I'm a physician assistant with BHN, and today I'll be presenting on intakes 5 days a week as our innovation at our OTPs. I just want to start off by saying how wonderful it is today to see so many friendly former colleagues and current colleagues here today. So let's get after it. I think it's prudent to first understand how we came to this innovation at our clinics. It helps normalize the patient's medical condition. Opioid deaths remain a leading cause of mortality each and every single day in the United States. These are our neighbors, friends, and community members. And if we're going to continue to recognize opioid use disorder and deaths as an epidemic, it's a call to have an all hands on deck approach and being able to admit patients 5 days a week. Secondly, the experience of our patients. For many of our patients, they have engaged in methadone maintenance through various points in their lives, and they may have had previous poor experiences, and that may range the variables and varieties of reasons why, including not being able to be seen when they're ready for treatment. And for our patients who may be methadone naive and be seeking out treatment for the first time, it helps break that stigma of that liquid handcuffs And in doing so, they can go back out to the community and change that narrative or that perspective of historical treatment with methadone. So this is BHN's current footprint in Massachusetts for OTPs. And how did we get here? In December of 2024, a private equity medical provider decided to leave the state of Massachusetts, in which they're operating 3 OTPs, one in Lawrence, Somerville, and Attleboro. BHN, understanding that how a medical provider leaving patients could rapidly destabilize them and return to use, decided to go ahead, fill those offices where their OTPs were at, and when that out-of-state medical provider closed, BHN opened the doors and was there to go ahead and treat patients that following day. So it's myself, Dr. Ruth Potee, and Chris Mulvey, our nurse practitioner, who managed the 3 OTPs and now our 4th OTP in Brockton since we opened up. And we utilize telehealth if a provider is not available. So we're not going to turn away a patient and say you're not being admitted today because a provider's out sick or unavailable to see you. And if we're not available, we utilize our Western providers, both MDs and PAs and NPs. And so you can see the breakdown. Since we opened BHN on the eastern side of the states, there's been 51 telehealth intakes for an OTP in Somerville, 17 in Attleboro, and 50 in Lawrence. And then we've utilized the West to complete 19 of those intakes. BHN is also in a unique position of being one of 5 entities that also has a mobile methadone van that's based in Palmer and Ware, being able to reach out to those underserved communities and being able to do those same-day intakes for those patients. So what if a provider is not available? We're not going to turn the patient away and say, come back tomorrow for the intake. There are multiple clinical and medical activities that can be completed until a provider is ready. For example, blood work. We know that for many of our patients, co-occurring disorders and diseases include Hep C. We're fortunate enough to have MAs at our sites, and then after drawing the blood, being able to go ahead and interpret it, and if appropriate, be able to treat Hep C within our clinics. Releases of information. I think for many of us, we can probably recall a story of a patient calling a panic because they needed to address a ROI. If we're able to preemptively address this for the justice system, for friends and family, and any other entities that they need to have a communication with our OTPs, it saves them, the provider, and ancillary staff stress. Psychotherapy, being able to have our patients engage on day 1 with counseling to understand what their goals in treatment are, their motivations, and also to be able to gather that biopsychosocial on the patient so we can treat them comprehensively. And lastly, a take-home video in preparation for our patients to be successful, being able to provide them an educational video on safety on how to take care of the medication when they are able to be eligible for take-homes. So what's next for BHN? Next week, we'll be opening up our 5th OTP in Hyannis, expanding methadone access and care for the Cape community. And then we'll continue to innovate to meet our patients' needs. Thank you.
Before I start my official time, I would like to mark the inaugural launch of the Josh St. Louis rule, which is present as if you are performing in a gospel choir. Okay, 5 minutes, go. Jeff Baxter, I'm the Chief Medical Officer for Spectrum Health Systems, and I'm actually glad I didn't prepare slides because I'm going to pivot a little bit and address some of the themes that came up this morning. So first, in terms of access in central Massachusetts, Spectrum renovated and opened a brand new site in the Main South neighborhood, which is really a high need neighborhood. We have 2 main OTP sites in Worcester, and with the growth and expansion of that second site, the census there has actually gone up by a full 33%, another 100 patients, and we're now able to offer admissions in Worcester 5 days a week. In addition to that, we have our mobile medical unit, which is now 2.5 years into operation. And we continue to be able to adjust to the needs of the community. So we have now 4 stops that mobile unit makes every single day. The men's shelter, the food program, the homeless food program. The city allowed us now to park at the transportation hub. And we've just started going to the newly opened women's shelter. And in addition, every winter, the city for the last 3 years or so has opened a temporary winter shelter and we'll be able to use the mobile unit to serve that shelter as well. Other access high points, we continue to work with the SNFs in Worcester. As you heard from other presenters, Worcester is sort of a hot spot because the SNFs have agreed that that's part of their job to take care of these patients. So we currently have a census of 74 SNF patients just in Worcester across 3 SNFs. Now that faced a critical challenge this year. They decided they didn't want to do it anymore. And so they started sending all of those methadone patients every day to the OTP to pretend like they were community-based patients and that they weren't going to need to pay for that. Disaster, people in wheelchairs, people in ambulances, people in stretchers, right, coming to us at our site. So we rode that out with them. Our executive director for that region is very patient. And finally, they changed their tune and we're back to delivering on site and offering admissions. The other challenge with those patients is that they often don't have their own home program, or because they've been hospitalized for so long, their home program has sort of discontinued their relationship with them. So we can offer to guest medicate them, but also we can offer to admit them new. And that's the same thing we've done with the opening of our medication unit in Westboro. Now that is on our inpatient campus, but having a medication unit there now allows community-based patients from that region to come in and medicate there. It also allows us to perform formal complete admissions for both OBAT and OTP, because again, some places are not comfortable accepting people directly out of what used to be called ATS units, sorry, whatever they're now, which we do all the time, but now we can fully admit them and tell the receiving programs that these patients are transfers. Finally, 2 last things I'll say. We are finally reopening our Leominster unit. We lost that under 6 feet of water 2 years ago in those crazy fluke floods that happened up there. After a 2-year fight with the city, we're going to be up and running within the next few months. And I will say we wish we had opened that first as a medication unit, because we would have been able to open about 3, maybe 4 months ahead of the schedule that it's going to take us to get all of the inspections and all of the licenses back in order. So keep that in mind for yourselves. If you're considering a medication unit, there really is sort of a lower bar, not quality bar, but a lower administrative bar to getting those open. And then finally, we've declared this next year the year of the patient experience. We launched that with a summit of our leadership group, and we've identified from patient surveys and from staff surveys 3 sort of pillars that we're going to look at in terms of our patient experience over the next year. That's our admissions process, that's our dose change process, and that's our take-home process, already of which we had adjusted for the new regulations through COVID, right? But now we're going to have focused attention on that. So we've launched that during Recovery Month with an automatic expansion of our walk-in call-in hours. We added an hour of access at every site for every 100 patients of census, just to try and move that along and bump the numbers and give patients access to get those assessments done and get those things approved. And now we are about to really break down our admissions process. We found that the time spent in admissions averages 2 to 4 hours because we get everything done in one day. I will say about 1/3 of that time is just data entry for all of the required data reporting that we have to do. But we're going to be breaking that down. We're going to be trying a new model of admissions I call reverse group admissions, where because there's a lot of overlap with what different providers have to record and our EHR doesn't crosswalk those into the different sections, we're actually going to try having the patient meet with multiple providers, right? The reverse of a group visit where you have one provider and multiple patients. And we're going to try and get that mutual documentation done all at once so the patient doesn't experience that redundancy. And I'll look forward to talking to you guys about that next year.
So I'm Matt Rogalski. I'm a site medical director. Oh, that's okay. I'm a site medical director for CTC/Habitopco/Discovery House, as people still know us in Rhode Island. I direct sites in Fall River, Providence, and Woonsocket. Really what we've been doing this year to improve access and improve care is trying to get methadone out of the clinic to where the patient needs to get it. So I was actually really happy to see all of these slides. So this is where we currently, so this is where we currently have OTP units. I can project. This is where we currently have OTP units in the red here. So we have Providence is just a bypass. I just kept it on Massachusetts. So you can see that we have, I think it's 13 locations. The Wareham and Yarmouth locations weren't necessarily labeled. And then this is when we expand out and we look at some of the other locations that we provide service and medication through. So we have medication units as referred to before in Spencer and then up at Barbara McInnes in Boston. I tried to color code it. I don't know how well it's coming out. We have mobile units that service Wellfleet and then at Quincy. And we have corrections units, one of them at Barnstable County, one of them at Massac, and one of them at Worcester County. And then the other thing is this is always old data. So the SNF relationships that we have had, utilizing some of the strategies that were discussed earlier in the OTP myths, that's all of the rest of those stars. So there's a lot of different SNFs that we have relationships with. And the way that that kind of plays out is that we, obviously we can take that referral, we can verify that they're a patient. If they don't have any admissions data, we can try to send a mobile team out to the site in order to get the pieces done that we need to get done so that we can immediately assume that prescription and start sending the medication to the SNF where the patient's going. I've done a couple of those in Rhode Island actually already, but it's a strategy that we're kind of evolving with. We're also leveraging telehealth technology, audio, video pretty heavily in order to make sure that all of the needs for assessment are being met. And so that's a lot of what we've done. Again, areas that we're going to be probably discussing more next year, continuing to expand and improve remote and on-site intakes in another location where we're often sending the clinical staff to do it as well as a medical staff person. Continuing to leverage technology to expand availability. Expanding beneficial partnerships. So any place that we can have that QSOA that's going to enable us to provide easier access to the medication is something that we're going to look at. And the last piece that I know people talk about, and I was really happy to see your study, Peter, academia. We have a joint venture going on with Tufts right now where there's a 144-bed behavioral health hospital that is being built brand new. So that's going to provide even more access for behavioral health beds. So that's a very important thing that sort of in the larger scheme of things that we're doing. And this is, I couldn't break out the Massachusetts number, but Acadia services about 80,000 patients daily across 170 OTPs. And that's kind of my count as of maybe July. And I've seen other emails that a couple of places have opened across the country, other places. How many researchers would drool to be able to access 80,000 patients daily worth of data points to get some of your population studies done? So we don't necessarily have a very fleshed out infrastructure to sort of support and collaborate with that. But if people come knocking at our door because they want to access patient data and do some of these studies, you can bet that we're going to figure it out. I'm already collaborating on one of my sites with Brown on a study, and it's not that intensive of a lift. I think it's something that for the good of the entire specialty, we in this group who serve a lot of patients just by the nature of our larger organizations, come talk to us. Thank you.
So we have time for questions. We have about 5 minutes. And if you have a specific question for a specific person, make that clear. Otherwise, make it general.
One very quick question for Peter. I'm Neil Lackwitz, Medical Director at Springfield CTC. Thank you. Specifically concerned about patients that do not have experience with methadone in terms of your rapid induction. We know that from old studies, about 10% of patients can be classified as ultra slow metabolizers of methadone. And we've all seen patients who stabilize or even become sedated at 30 milligrams or less that we didn't expect. So I just wonder how you handle methadone naive patients on induction.
Thanks for that question, Neil. Well, as you know, no one size fits all for methadone dosing. And while it looks like, in one sense, we're providing cookie cutter protocols for induction on methadone, that's really not the spirit of this. The spirit is to encourage our providers and our teams to consider higher dose inductions and get people on therapeutic doses faster. That said, we're in the process of admission. We're trying to assess people's prior history with treatment, with their proclivities toward treatment, and any other things that may influence decisions about dosing. So, as I mentioned, we still are, using lower dose protocols and dosing strategies for a lot of our patients.
Hi, Ari Kriegsman, BHN Springfield. I'll kneel down a little bit. Just to piggyback on that question from Neil, and also for all y'all, and maybe even to source this, I think we all are in this practice of these sort of escalating doses of 40, 60, 80, 100. I've been asking myself where that comes from. It does seem like maybe it builds in some safety for someone maybe who's never been on methadone before, where maybe you'll actually get to 60 and they're good there. But I also notice I still do this sometimes with someone who I know has really high tolerance, has been on methadone before and tolerated high doses. I just sort of wonder about that practice, and if we're doing a disservice for those first few days of actually starting somebody at 40 instead of going I think of somebody who maybe has been at a clinic for a month, they're on 160 milligrams, they're injecting 5 bundles a day. Does it really make sense to do the 40, 60, 80, 100? So I'm just sort of wondering where that came from, if it still makes sense for all these cases.
I generally say no. We should try to be dosing based on our patient's needs. I'll start people on 50 milligrams if they're experienced. And depending on their tolerance, I'll start them on 50. And generally, I'll go up 10 a day. But so for some patients that have really high tolerances, I'll go up 15 a day, sometimes to 140, so that they're there within about 10 days. And then I'll keep them at 140 for 3 days so that they can kind of equilibrate and then see what they need from there. But there's, especially when you know somebody's previous tolerance to methadone and you're fairly sure that they have a really high tolerance based on their illicit use, there's no need to do that. I don't think you should be flexible.
Yeah, I think that's maybe was my question. Maybe it wasn't totally clear. It's like, why don't we just give them 80 the first day?
I mean, I think BSAS and SAMHSA would probably support it, but if you document in the chart, like, listen, I know this person has a super high tolerance, I'm going to start them on 80. I don't think we would get any problem. So.
But basic kind of pharmacology question. If someone's been using high dose fentanyl, I'm Michael Beer of Boston. If they're using fentanyl, have they induced their metabolism for methadone with, the cytochrome and CYP system?
I don't want to. I mean, that's kind of what I do sometimes with AWOLs, Michael, right? Like somebody's gone for 4 or 5 days, they're on 120 milligrams, but they've been using fentanyl a gram a day. I may not change it. I may change it 10 milligrams a little bit just because, yeah, their receptors have still been full. So why would I drop them 40 milligrams and give them worse withdrawal symptoms that might cause them to use more fentanyl and then increase their tolerance more? So.
I just want to make sure people heard BSAS's response, which is it's very clear in the final rule. The old rule said clearly 30 milligrams, you could add another 10. It always actually said you could override it with medical decision making. And now they spelled it out even more clearly. So you can start somebody at 80 milligrams a day, period. You can. You don't have to start 40 or 50. There are reasons programs are just embedded in their system that the system says you must start there and tomorrow you can go up. That's different. But again, the rule says a medical decision can be made. It just needs to be documented. And these guys were great. They held on time. They gave you new information. We have great methadone clinic leaders in this state who are often setting the standard for the entire country. And so thanks to them. And we have our next speakers coming up right now. Thank you.